Good afternoon, everyone, and thank you for joining us today for our Heal Connection sharing session. Today's session is the second part of a two-part series on community partner insights to strengthen research dissemination. In August, we hosted one part of the session focused on pain. Today's focus will be on substance use disorder. I'm Eden Buell. I am one of the moderators for today's session. I'm with Chestnut Health Systems Lighthouse Institute as a post-baccalaureate trainee for the Justice Involved and Emerging Adult Population, or JEEP initiative. I am also one of the facilitators for the Heal Connections Lived Experience panel, and I have both direct and indirect lived experience with chronic pain conditions and substance use disorder. I'll now turn it over to Sierra, who will serve as the other moderator for today's discussion.
Thank you, Eden. I'm Sierra Castedo de Martel. I'm with Chestnut Health Systems Lighthouse Institute as well, also working on the JEEP initiative as an assistant research scientist. And I'm also one of the facilitators on the Heal Connections Lived Experience panel. And I'm a person in long-term recovery from substance use disorder. In our session today, we are joined by Marissa Kluk, a certified peer recovery specialist, doctoral student at East Tennessee State University, and a person with lived experience of substance use disorder. We are also joined by Kiana Madison, a multidisciplinary artist and a person with lived experience of pain and substance use disorder. Ronald Simpson Bay, the Executive Vice President of Strategic Partnerships with Just Leadership USA, and Anthony Solandi, Chief Program and Business Strategy Officer with the National Harm Reduction Coalition. For today's agenda, each of the panelists will give brief remarks to introduce themselves. Afterward, we'll dive into our panel discussion, followed by a question and answer session. I encourage you all to ask questions in the chat throughout the sharing session, and we'll address those questions during the open Q&A session. So today, we're excited to learn from our panelists about the best formats and channels for engaging communities in research and results sharing. By the end of this meeting, we hope you'll have gained insights on successful approaches to identifying and engaging stakeholders to reach communities and populations experiencing substance use disorder to bring back to your own research teams and specific projects. So now we're going to hear from our panelists. Panelists, please go ahead and turn your cameras on when it's your turn. First up is our panelist, Marissa Kluk, one of our living experience panelists.
All right. Hello, everybody. Thank you so much for joining. I am honored to be a part of this panel. And so to get started, I am someone who does have lived experience with substance use disorder. So really all of the different substances, opioids included. And currently, so I have I wear many hats, I'll say. I think a lot of us do. So as much as I am someone with lived experience, I am also, as was mentioned, a doctoral student at East Tennessee State University in Johnson City, Tennessee. And I'm also working with the Addiction Science Center at ETSU as Director of Recovery Ecosystem Alignment. So I look at kind of a systems level look at our recovery ecosystem in the region. Now, what an important topic to talk about today. And, you know, coming from someone with lived experience, I'll just share about a little of my experience while I was still in active addiction. I was definitely someone who would engage in research studies, mostly for the stipend. I am not even going to lie, and not really paying attention to what was happening or what was going on. I was just kind of there to collect that gift card or whatever it might be. That experience is super valid. And, you know, I would not turn people away if that's what they were doing necessarily. Their experiences are still extremely important to be included in any research that is happening. But you might see that in folks that you do work with. Now, as someone in recovery, I am a lot more careful about things that I get involved with. I don't do things for stipends or anything along those lines. I'm a much more honest person. At the same time, though, you know, I do think there's a lot of I hate to say that the word seems so severe, but exploitation of people with these experiences. You know, I think a lot of times people are looking for just the trauma that we've been through and kind of highlighting that and trying to make some kind of headline about it or what have you. So today I'm a lot more careful about different research studies that I get involved with because I want to make sure that the purpose is meaningful and is going to make some kind of change for the future to improve on our systems that exist. And so, yeah, I think that's kind of where I stand today, like on that topic in general, as a student at a university too. My center is very supportive of me being in recovery and all of that. I will say it has been difficult at times to work with other centers. I've been engaged in research that maybe I wasn't involved in the publication of the findings. So, maybe I was involved to like, hey, will you give your opinion on this? Or hey, can you give us feedback? But I was never part of the actual publication or final presentations that happened or anything like that. So there's a lot of tokenization, I feel, within this space for people that are in recovery or are, do have living experience of opioid use disorder or substance use disorder. It's a very real problem that I do see. So I know from our center's perspective, we definitely are careful on making sure we're really getting proper consent from folks and being involved and actually sharing back results on different findings that we get from our research and making sure the people that were involved are a part of that process if they want to be. Not everyone wants to be, but some of us do. And so really just trying to create those opportunities for folks. So yeah, I think overall, I mean, that's just kind of my experience in a nutshell. I know we'll have a lot more questions that we'll get into the nitty gritty of these experiences too, but overall, that's kind of what I have to share, just a quick little highlight. I will also mention though too, as a certified peer recovery support specialist in the state of Tennessee, I do work a lot with folks that are in active addiction or are seeking recovery. And a lot of times we do engage in these conversations of, what kind of recommendations can we provide for folks? And these do need to be evidence-based. The research is so important. I'm not just trying to hate on research. Research is extremely important. And we definitely want to be well-versed in the current science. So as a CPRS, I definitely try to engage folks and, help them find themselves in the research that exists and in the science and try to make the best decisions for the recovery journey in an evidence-based way. So that's what I have.
Thank you so much, Marissa. With that, I'll pass it to Kiana Madison.
Namaste, everyone. My name's Kiana Madison. My pronouns are she, her. It's a pleasure to be here with all of you. I'm going to share about my health journey, in particular, my journey as a person living with chronic pain and being an advocate in the pain community, because I feel like from my experiences, the intersection of living with chronic pain and then dealing with substance misuse, abuse, and dependence and tolerance, all of that is very intertwined with the community members I work with. So I'm going to share a little bit about a few points from my story that have really shaped the way I think about creative ways to disseminate research information that can make a difference for patients, communities, and practicing professionals. So for myself, I have lived with chronic pain since I was a child. I was around 8 years old when I had a Pseudomonas bacteria infection in my left ankle that caused life-threatening sepsis. I lived in the hospital for several months, and I had part of my ankle removed. And during that time, I experienced a lot of acute and chronic pain. But because I was a child, there was a misconception that children are resilient. Children don't really experience pain in the same way as adults. And so we don't need to pay attention to that. And that was a very traumatic experience for me, living through such intense treatments and not receiving any care and thought really around managing my pain. As I got older, by the time I was 16 years old, I had a bone deformity in my left ankle where it had been impacted by the Pseudomonas infection, and it was causing me daily pain and mobility problems. It made it difficult for me to engage in just basic day-to-day responsibilities and to interact in my school life at that time. Eventually, I had to undergo another reconstructive surgery to address the issue. And after that surgery, I remember that I was given Tylenol and ibuprofen, even though they had cut off part of my bone and put a screw into my ankle. And when asking with my family about the pain management, we were told, oh, well, you don't really feel pain in the same way. I share this because I want to bring up the intersections of race, of gender, and class into thinking about these conversations about the importance of, you know, disseminating key research-based information that can make a difference. Because where I was living in Missouri, a lot of the doctors would say things that indicated that they didn't think that African American people felt pain the same way because their skin was thicker, um, because of, you know, false information that had been peddled to them in the past, and a lack of having more current data and research that definitely debunked that. So from 16 years old until I was 24 years old, I lived with daily untreated chronic pain. And because of that, I found that as a teen, that led me to seeking different types of substances to try to self-medicate because I was unable to get the type of care I needed. Um, I don't think at the time I was consciously going, oh, I have this pain, so now I'm going to use this drug to support me. But it was more of, you know, trying to cope emotionally, psychologically, what was going on, and with the physical pain. And I think that's an important part of thinking about, you know, the stories behind what leads to folks into substance misuse abuse. Um, by the time I was 24 years old, I had a doctor that, for the first time in my life, that actually believed me about pain and was himself someone who referred to research to drive his practicing decisions, and shared that information with me as a patient. And that was making a difference for me. However, when I would change doctors due to health insurance changes, or when I moved, I would be starting this process all over. And I noticed that the majority of specialists that I had access to had no knowledge about pain management, about the research around, you know, warning and supporting patients so they don't become in danger of becoming addicted to opiate medication when that is being prescribed for pain medication. Um, and so in the early 2000s, I was prescribed opioid medications for the first time. And I knew nothing about opioids. The prescribing doctors that were prescribing these drugs gave little information in regards to the risk with that, the things to manage and to look out for. Eventually, I started to experience physical dependence, tolerance. I was on very high doses of opioids, even though I was under the supervision of a doctor. My body was becoming addicted to that. And when I started to realize that I was moving into this area of physical dependence and starting to have withdrawal symptoms when my dosing was changed, I wanted to come off opioids. And when I went to medical specialists that had prescribed these drugs, they didn't know anything about how to bring patients safely off of that, especially chronic pain patients. And that was shocking. That was frightening. And it was really scary to see that there were prescribing doctors and specialists that did not understand and seek out any of the research around the abuse that can happen with opioids, or how to safely bring patients off of that. And so in my situation at the time when I wanted to come off of that, I had to seek creative outlets to get that information. So it would be talking to what I call bridge walkers. Bridge walkers, to me, I define that as people who move between different spaces, who try to be advocates in informal ways. And so reaching out to individual community members with lived experience to find out, what do I do? Or do you know of any spaces or specialists that can be helpful, that are more inclined to be basing their practices off of research that makes sense? And that's how I would access information to support me and find resources that could support me. In one case, I had a doctor, I had been on morphine for a year for chronic pain that I was being treated for. And I had a doctor just say, "Oh, you can just stop taking it. You don't need to do anything. You don't need a taper." And so I did that and ended up in the ER and in the hospital from the side effects and the withdrawal. And when trying to get help from that doctor about, this happened, they just shrugged off that, situation. And we're like, "Oh, well, I don't know. You're got to find somebody else." And so those experiences really shaped me with thinking about why I needed to access research as a patient to advocate for myself, but also the importance of trying to help share that information in different kinds of spaces. And so when I think about the different ways that we could disseminate research, so there's not that 17 to 20-year gap between spaces being able to take up that research, I think about 3 different buckets of people that we could be focusing on that can support some of the efforts to disseminate that research. So first, I think about lived experience experts. This might be people who are direct advocates, but it may just also be different online communities, in-person local communities, where giving them that information can be helpful because a lot of other people go to those people to get information that can be supported. So utilizing those folks, utilizing bridge walkers. And so for myself, as someone who works in the recovery community as an artist and wellness facilitator, I am constantly trying to bring research to the different community groups I work with, to participants and peers I work with, and to help code switch and help support people with learning how to understand research results that can support them in their healthcare decisions and in advocacy. And then lastly, I think about medical professionals who center patient education as something that is key in treatment of people living with chronic pain and people who are dealing with substance misuse and abuse and who are in recovery, and helping those folks with passing that information. I know in my experience, I had different specialists who made that a part of the treatment protocol to understand research together and to understand how to use that to advocate for myself. So I know I'm at time, but those are a few experiences I just wanted to share. And thank you for the opportunity to speak with you today.
Thank you so much for sharing your experiences, Kiana. Next up, we'll hear from one of our association partners, Ronald Simpson Bay.
Good afternoon, everybody. It's an honor, a blessing, and a pleasure to share the space that you hear today. I am Ronald Simpson Bay, the Executive Vice President of Just Leadership USA. And I'm here today to give an organizational overview of the work and approach to research and the dissemination of the information that's generated from that research from the perspective of people with lived experience. Just Leadership is a national level criminal justice reform organization that was founded in 2014. It was founded by and operated by people directly impacted by the criminal legal system. We were founded on the principle that those closest to the problem are closest to the solution, but furthest away from resources, power, and opportunities to effectuate change in our communities. Our mission as an organization is to center and amplify the voices of people directly impacted by educating, elevating, and empowering them so that they have the tools and resources to self-organize and advocate for themselves, their families, and their communities. Because together we seek to build a fair and equitable America. And we have a two-pronged approach to our mission. The first prong is leadership development. We have a leadership development training for directly impacted people. And we also do policy advocacy work on the state, local, and federal levels. On the leadership front, we have two leadership development training programs. One is called Leading with Conviction, and the other is Emerging Leaders. The aim of our leadership development training programs is to meet the mission of our goals in centering and amplifying the voices of people who are directly impacted. And to date, we are proud to say that we have served over 1,700 national leaders in 45 states plus Washington, D.C., who have gone through either one or both of our training programs. So that gives us a real vast network to operate from. On the policy front, we have what we call the Just Us Coordinating Council. Back in 2022, our president and CEO, Deanna Hoskins, she took the famous quote by Congresswoman Shirley Chisholm, who said, "If they don't give you a seat at the table, bring a folding chair." Deanna built upon that notion, and she said, "If they don't give you a seat at the table, build your own table." So from that premise, we created the Just Us Coordinating Council, which is a national federal policy table led by and created for individuals who are directly impacted. The JCC forms the connective tissue needed to catalyze full participation in policy changes for formerly incarcerated people and directly impacted individuals in their communities. Currently, the JCC is made up of over 400 organizations and individuals, and it is the connective tissue that demands change through creating a united purpose for a united voice to establish united power. And from there, we are currently doing a lot of policy work in DC. We are currently working on a couple of research initiatives as well. We're partnering with Yale on two particular health-related research topics. One is around called Advance, which is dealing with the uptake of vaccinations in jails and prisons. And the other is through the American Heart Association, which researches the impact of incarceration on heart health of incarcerated people and their families. So we are very involved in this research notion, and I'm looking forward to have this conversation with you. Thank you.
Thank you so much, Ronald. Now we will hear from our other association partner, Anthony Salandi.
Thank you. My name is Anthony Salandi. I'm Chief Program and Business Strategy Officer at National Harm Reduction Coalition. National Harm Reduction Coalition started in 1993, and it emerged as a response to the dual epidemic of HIV and Hep C that disproportionately was impacting people who use drugs. The organization was born out of a grassroots movement driven by activists and community leaders to address largely punitive and abstinence-based policies that were ineffective and harmful. NHRC the impact today goes beyond its original scope, and it encompasses initiatives to address complex and interrelated issues of substance abuse, public health, and other social justice issues. National Harm Reduction, its North Star statement is to create safe spaces for dialogue and action that helps heal the harms caused by racialized drug policies. We have 5 areas that we work in: policy and advocacy, national and regional convenings with community-based organizations that seek to build their capacity to do harm reduction services. We do training and technical assistance all over the US, DC, the Virgin Islands, and Puerto Rico. And we have an overdose prevention, one of the longest state-funded overdose or city-funded overdose prevention program called the DOPE program, the Drug Overdose Prevention and Education Program in San Francisco. And we also do some research, and we have a large repository of resources and publications that could be found on our website. I'm going to address dissemination throughout the research process. And full transparency, this is a part of a curriculum that we do for PIs and their research teams at institutions of higher education. at clinical research organizations, contract research organizations, as well as community-based organizations who want to feel empowered to partner with those entities. So I'm going to go through the whole research process because my belief is that dissemination is a component of throughout the research process. And so from the RFA, RFP development stage with government partners, they need to include, we believe they need to include people with lived and living experience as they are developing the RFP and RFA. One of the organizations that do this really well is PCORI, Patient-Centered Outcomes Research Institute. They really are intentional about creating spaces and opportunities for people with lived and living experience in the creation of their RFPs and RFAs. And also have requirements in their RFPs and RFAs for people who are responding to those proposals to include a strategy for engaging people with lived and living experience. I'm going to go through this because a lot of this hopefully will come out in the discussion period and the Q&A period. People with lived and living experience, as well as community-based organizations, should be included in the research idea development. So as you're developing your aims, you should be including people with lived and living experience in that activity. This hopefully would bust some of the flawed assumptions that PIs and their research teams have, and it will decrease the marginalization of people with lived experience, especially in drug use. And oftentimes it will decrease the stigmatizing language and the use of stigmatizing language in communication in general. And I can't tell you how many times that I would go in and a research team would show me a survey or an instrument and stigmatizing language would be in there. And their question would be like, well, why can't we use it? Because I said how, it will turn people off. They may not give you the right, truthful response, and therefore you have terrible data in the back end. So it's really important to use non-stigmatizing language in your surveys. In the proposal development, is equally important to engage in the community, especially in research design. It's vitally important. So for example, one example is a research team came and they were having, they wanted some consulting on their research design from a community standpoint. And they were doing a research project on pregnant women and drug use. And I pointed out that one, you don't have any money in your budget for transportation, and two, it would be great if you had daycare services at the point, at the place or the site where you are getting these participants to complete the surveys. And so those types of things PIs and your research teams are not necessarily thinking about, but when you bring in people with lived and lived experience, they would come up with that. Budget is extremely important. So putting in dissemination, developing a dissemination plan and budget and including money in the budget for it is extremely important. And oftentimes PI and research teams say, oh, our budget, graduate student salaries, research teams, PI salaries are all, it's taken up a lot of the budget, and we just don't have a lot of money, for other things. And one of the things that I suggest to PIs and research teams is that 65% NICRA, negotiated indirect cost rate agreement that the institution has, sometimes upward of 65%. I would say to go to your dean of your college or your school and ask them to contact the provost office or the dean of research and try to negotiate some money back. Yes, some money comes back from that NICRA money to the school, and then some of it goes from the school back to the PI and their research team for the project. But there are instances that I can name where PIs have done that and have recouped some of that, more the 62% to then go ahead and do a budget modification and include some of that money for community-based organizations and other things. In addition, people with lived experience can really inform your arguments or your retort to some of the IRB arguments that, say, for example, a person with lived experience on your research team may say, hey, listen, $25 compensation for research participation is really not good. It's not good. So you try to say, okay, let's move it up to $50 or $75 for an hour participation in your research activity. And then you submit it into your IRB, and the IRB comes back and say how that amount is coercive. And so the people with lived experience can actually build in some arguments on why that's not, because they're the ones that actually spending the money, that the compensation that they're getting for participating in the research project. Next, I'm just going to mention this for government partners really quick. The proposal review process, inherently, that is a power dynamic that does not work well for community-based organizations who are maybe even trying to apply for a research grant. SAMHSA has done something really good recently, where they took away the requirements for a master's degree to be to be a reviewer, and I think that's admirable on their part. Doing the research project in itself, it's trying to include people with lived experience in the decision-making process. That's really important. If you're partnering with a community-based organization, also realize that that community-based organizations don't often have the resources that an institution of IHE would have. And so, sharing resources is extremely important. Mutual aid is extremely important. And also involving hiring people with lived and living experience as research staff is also important. And I can't stress that. I can't stress that enough. Dissemination activities, and this is the crux of the matter. And again, dissemination activities doesn't start when the research project ends, right? Dissemination activities start in the very beginning, right? By including your community-based partners. And so part of dissemination, as we all know, is papers. And so what I often stress to PIs and their research teams is to actually, at the beginning, talk about co-authorships on papers and establishing those contractual obligations, and really don't relegate community-based organizations and their staff, their primary staff on that research project, to the acknowledgement page. That is so demeaning on so many levels. Community-based organizations can also give you really good insight into your data, especially if you're doing quant-qual methodology. And so, getting someone to really know what's happening on the ground, on the front lines, is vitally important. Co-create the dissemination strategy. As you're building your budget for dissemination strategies, include funds for community-based organization staff to attend conferences, professional conferences, and just don't do it as like, oh yeah, you can come along, but actually engage your research staff with community-based organization staff to attend a professional conference. Give them the conference book, and say how, what are some sessions that you would like to go to, and sort of say, okay, I'll come along with you and help you negotiate. Don't just, pay for the registration fee, drop them off at the front door and say, go at it. And then this is another really important part, is PIs and the research staff should really attend local conferences and local meetings with their partners, right? And so, and vice versa, right? So, there are some questions that we are going to talk about where, at what points do you invite PIs as subject matter experts to speak at your community-based conference? Well, do they ever ask us to come to their conferences or their seminars or workshops as a subject matter expert, right? And so those are the things, like when you start framing it that way, it's a bit different. And I think that how it would lead to long-term partnerships, continued mutual aid, research that's not helicopter driven. You drop in and you drop out. And also my last thing is that NIDA should create a person to live and living experience research subcommittee at the advisory council level. I know that they're having a discussion about it right now. I think that how that's an excellent idea, and hopefully it will come to fruition. As I said, we do technical assistance and training both for CBOs and research teams as well as departments around dissemination and engaging community-based organizations, national harm reduction. And I'll say one last thing, and we could talk a little bit more about it in the discussion. Research teams oftentimes contact us, and I'm like the person who actually feels those calls. They'll contact us, and one of the first things that some of them will say is, "Hey, would you like to be part of this research? This is what we're doing. We'd like a letter of support, and this is what we have for you in a budget." And it's oftentimes it's a little bit, right? Or can you be part of a community advisory board, right? And then you have some PIs that will reach out to National Harm Reduction and say, "Hey, we'd love to know what you're doing," and build a trusting relationship over time, create an MOU. We get invited to seminars, they get invited to our seminars, and then, right, they'll approach us and say, "Hey, we're looking to do this. Would you like to participate?" And at that point, yeah, we'd be willing to do it, because we consider you an ally, and not this entity from IHE who is dropping in and doing research. Thanks.
Thank you, Anthony, and a big thank you to all of our panelists for those wonderful introductions. That is going to lead us into our panel discussion. But before we get started with the panel discussion, I just wanted to give a quick reminder to all of you in the audience that folks can put questions into the chat, and we'll get to them a little bit later in the session. So feel free to put those questions in the chat throughout while we're talking. We're going to catalog them, collate them, and bring them up in a kind of an open Q&A session. So my first question is going to be directed to our lived experience panelists, Kiana and Marissa. So think specifically about times when you or a person in your community received information that made some kind of meaningful impact on their substance use disorder or their management of their substance use disorder. How did they get that information? How was that information obtained?
In my lived experiences with that, I noticed that information is obtained in a variety of ways, and it's necessary for all these different ways when thinking about accessibility. So trusted people, let it be it's through community organizations or businesses. As someone who identifies as part of the LGBTQIA community, spaces that were inclusive of us, though, even if the business had nothing to do with substance misuse or medical issues, often acted as these bridges for information because people trusted the folks that were there. And, I would say also with social media, social media, there's so many different aspects to it, but like online groups, TikTok, Instagram, some of the infographics that are used at times, but also having hyperlinks back to where did the original research article come from, or the consortium of community partners working together, and then having downloadable information online. So that's some of the spaces in which I've seen and have experienced getting information. That said, though, I'm a big advocate for don't just pick one or two ways. you need to think about all those ways because there's a variety of different learners and community members. And as you think about accessibility, if I'm low vision, can I access this information? If I am deaf or hard of hearing, how is it different for me to access this? Depending on the communities, like, is this bilingual or available where I could listen to this information instead? So just keeping that type of info in mind, I think is critical.
That was excellent. So just to add on to that, one of the things I was thinking about was just our association partners as well, and how instrumental they are in sharing different research with folks with lived experience. I can't tell you how many times I did consult, the National Harm Reduction Coalition's page on different things, because I trust y'all, and harm reduction is part of my story. It is part of my recovery. And that's, it was definitely an amazing resource for me. So I think there are going to be different associations for folks on different points in their journey. So I do think finding those associations that are going to be helpful and trustworthy for individuals is really important. Sometimes people do, look at, say, universities or academia, and they're like, I don't know if I trust y'all. Like, I don't know, I might have had some bad experiences with y'all, like, or I felt exploited by y'all at one point. I will say, even working for a university right now, it's pretty weird, so, but it's good. And I do see inside, like, it's not this, like, scary corporation or anything. It's not just trying to exploit people for their stories. At least many universities are not trying to do that. And there are networks to prevent that from happening too. So I'm very grateful to be learning that now, but especially my active use, I'm like, I don't really know if I want to do or listen to any university telling me what to do or how to use or whatever. As far as recovery goes, I still, draw on similar associations and all of that too. Word of mouth is extremely, extremely important in our community in general. And so that's kind of, I think, a lot of people's preferred way to at least first hear about some kind of research finding, whatever it may be. And I try to talk about things really casually with people. I'm not going to give them the full, like, in-depth overview of a research article, but if folks do want more information, trying to find those areas where we can share that. I really like what Kiana said too about like linking an article or something. So if someone didn't really totally trust or wanted to read more or figure out more for themselves and read for themselves, they can. So putting that autonomy in the hands of someone who's going to actually be digesting the information is super important. Trying to think what else. I know, like, there's a few little golden nuggets that I usually share with people, like, from the research world. And one of those is just, statistically speaking, recovery is not just possible, but it's likely. And that's a huge revelation for a lot of people, that they can see themselves. Yes, absolutely, that there's hope, there absolutely is hope. If you do want recovery, not everyone's going to want it either, and that is okay. But if you do want it, like, it is likely with the right supports in place. So that's something that I love to share with people. I actually got that from the executive director of our recovery community center too. She says it all the time, and it's like just so impactful when it's said. And just like medication assisted treatment as well, or MOUD or what have you. It's so important for a lot of folks. And we have science to back that up too. So if anything, it keeps people alive and it helps people in their recovery. So, I'm very much a huge supporter of whatever it takes to help people be healthy and lead meaningful lives. So those are two little nuggets that I'm like, I definitely like to share with folks. Yeah.
Thank you, Kiana and Marissa. You said something that spurred on this question I have for our association partners. So there is so much information on any given topic. How do you determine what to share with your members?
It's a really simple answer. You ask them. You ask them, right? And oftentimes we come from the top and say, this is what we believe you should get. And that oftentimes is way off the mark. Sometimes it is, but sometimes it's not. Often it's not. And so you ask them, like, what do you want to, what information do you want to get? And so, and I'll give you a good example. RTI International has a grant from CDC where they send out an annual survey of over 400 SSPs, and they ask them a lot of questions on the services they provide, but they also ask them about communication. How best do they want the communication? What platforms do they want it on? What's the topics do they want it on? And so come to find out, like a lot of people like issue briefs, right? They like, stuff, one pages on best practices. They like policy briefs, right? They want it predominantly on Facebook. Because that's their primary way of communicating with their population. They like some like digital messaging, right? Because they want to lessen their digital footprint, right? For all sorts of reasons that we could think of. So it's and then the topics vary, right? And so people want information about convenings and large conferences. They want funding opportunities, right? Announcements, right? They want stuff like that, right? It's and so it's you don't know unless you ask the community-based organizations what they want, and you can't do that unless you have a partnership that's based on a trusting relationship, right? Because imagine somebody from an institution of higher learning coming in and saying, hey, we have research. We're trying to find out, we want to disseminate it, and we have it in this platform, right? It's like Marissa says, sometimes the trust isn't there in the community, and we need to build that trust. I get excited at these things.
Yeah, I'll piggyback off of what Anthony was saying. Because we are an organization that we operate by people with lived experience, so we kind of have the pulse of what they want to hear and what they want to know. I'm personally have been over the history of the organization, the organizational point of contact for our leaders. I used to be the alumni coordinator, and so I have direct contact with all of them through the emails, phone calls, whatever. So I kind of have a pulse on what they're looking for and how they want it. Plus, I'm connected to a lot of external organizations and information networks that I share the information with them that I get. Because of our network, like Marissa said, word of mouth is a very, very powerful tool, communication tool. Our leaders share a lot with each other, and we share a lot with them. We manage a direct mailing list that we share information with them, and they seem to appreciate that. We also have a external communication platform that we call Engage. It's only accessible to our leaders. And on Engage, they talk to each other, they share ideas with each other, and they have access to a vast array of information that we put on there because we're involved in a lot of research and policy efforts. So whatever we come up with, we put on Engage, and it gets access to it from job opportunities, from conference speaking opportunities, from reentry services, all type of things we put on our Engage platform. We also have a national policy roundtable that I mentioned earlier called the Justice Coordinating Council, which is made up of over 400 organizations and individuals. And it's a standalone website that they can go to and get information as well around funding opportunities from the federal government and their state and local governments, economic mobility and healthcare issues. And we also use social media, traditional social media accounts like Facebook, Instagram, Twitter, LinkedIn, and what have you. And one other way that we found very effective, because we have such a large network, we hold focus groups every so often, just to touch base with them, see what's going on, and ask them questions. Well, what can we do to better serve the work that you're doing? And then they inform us on what they need to know, and it helps us inform in the way that we disseminate information to them and how we even form and develop our leadership development programs.
Thank you so much, Ronald and Anthony. And I also wanted to just kick this same question over to Kiana and Marissa. And Kiana, I saw you wrote a little bit in the chat. you know, you may have a different looking platform, right, than our association partners, right? But you're still making decisions about what you communicate to people in your community. So maybe you could speak to that a little bit, walk us through, you know, how you make decisions about what kind of information to share.
I mean, building off of what Anthony and Ronald said, so much of that just resonates. I like to ask a lot of the community members I work with on what are you interested in, what do you need, and coming back to ask that question regularly because it changes based on the context of what that, let it be individual or individuals and groups are managing and dealing with. And so as a former educator, I just try to always track what I'm observing too in what's needed, and then sharing that information and asking too, like, how would you like that information? What's the best way for me to communicate that information? And I track that in detail with the different clients and organizations and individuals that I support in the recovery community here. So that's what drives it. But then also, I try as a practitioner and bridge walker to keep up with current research that is just coming out that I can get access to. And then as I'm reading things, if I see information that I think could really make a difference, then I just choose to go, hey, this is something new that came out in the last like 6 months, the last 12 months that you at least might want to be aware of. And I see in the chat someone's mentioning like with code switching. Let's see here. Hold on, just reading your whole comment before responding. So, and if someone can't see this, the comment from Glenn is, Kiana mentioned code switching. One of the issues I suspect arises often is the difference in facility with language, reading levels, etc., but also the variation in how concepts are expressed in different idiom or use of language. What are some methods for addressing that upstream in grant proposals? Glenn, you raise an excellent point. And in my experiences, some of the things that me and other partners have talked about with code switching is depending on that community, like, and what they're saying they need, doing things like other addendums, like, all right, what glossary are we creating to go with this? Or what's the you know, what are ways for us to help people learn up and not to assume that people don't want to learn? Because that's what I find happens often in some of my communities is, oh, well, this language is too difficult, so we're just not going to try to help you learn up on that. And that can get really frustrating, opposed to, all right, help break it down. Help people learn up how we can do that. And perhaps in some of the grant proposals, based on talking with the community partners and community members that you're working with, taking their ideas because it's so contextual, then building in some, hey, we're going to take time to build in these tools, or we're going to build in time where we are, you know, working with our partners, paying for their time to sit and create some of the like supporting resources that can help someone break down the research and information. So those are some of the things that have come up in the spaces I have worked with, but definitely not just assuming people don't want to know or aren't capable of learning.
Can I chime in briefly on that? Because I mean that Kiana, you raised a very, very important point when you talked about the grant, the people that's issuing the grants, addressing them up front and getting the impact of people with lived experience. I have personally offered to read the proposals from grant makers and their material, and I've been able to show them gaps in the way they're thinking, the language that they're using, and which is caused by the lack of including somebody with lived experience from the beginning of the process. An example, a couple of years ago, an organization reached out to us after they had gotten a grant from the BJA, Bureau of Justice Association, and they asked if we could be a sub-grantee with them. I read the proposal and pointed out the gaps because they didn't include us from the beginning. And so I said, we will work with you guys, but we need you to make these changes in your proposal. And their response was, well, the train has left the station and we're not going to change it now. And you know what happened? Their grant ended up being denied when they got the feedback. It was based on exactly the points that I pointed out that they were missing in their proposal. So it is very, very important, as Anthony and Kiana pointed out, to get people lived experience on the decision making when you first launch, and don't roll it out and then say, here you go. Tell us how to implement it. No, we need to be involved at the very beginning of the implementation. I mean, the developing process.
I love this conversation. I just wanted to add as well, usually when communicating out different research pieces, I try to keep it as simple as possible. I realize I've reflected quite a bit. I come from some privilege, right? You know, I'm educated. I have 2 degrees behind my name, one maybe in the making. It's taken a long time, but you know, I have a different reading level than a lot of folks. And so honestly, a lot of times I'm like, all right, let me try to explain this idea or concept as if I was talking to one of my family members or something along those lines and just break it down. One of the most helpful things I think for a lot of people is when looking at a different research article or what have you, seeing those main talking points or key points or just seeing that summary is really helpful to at least you know, try to better understand what is this research article even saying instead of just getting lost in the methods and all of that, because a lot of people really it's above, you know, what they want to be reading, to be honest. It's something that I'm still learning even myself. But one of the examples that I can think of is an individual I was working with was recognizing that they were still using cannabis, but had quit everything else. And it was really sparking their PTSD actually in a really negative way. And so one of the research articles that recently came out actually was one of my old sponsors shared it with me, which was kind of funny. We're big nerds. It was on if you used heavily during adolescence, it may actually have an adverse effect and not a very therapeutic effect if you use it heavily in adulthood, for if you experience trauma. So just having that conversation with an individual, and then he did ask me like further, he's like, can you actually share that with me? Because I'll be really curious to read more about it. And I really identify with that. I'm like, I honestly do too. So we had that, you know, connection there. And it does sometimes take just that simple conversation of, you know, trying to relate to someone. And that's where peers really come into. I think one of the most wonderful ways to share research finding is through peer support, especially for those, you know, different research findings that we identify with as well, to share that with others. I think it's really helpful.
Thank you so much. This was a great discussion. I'm going to move us into another question now, focusing in on something mentioned a little bit earlier, social media. So social media can be a really important tool for reaching broader audiences, but it's also a source of misinformation. So how do we navigate parsing health information from social channels?
I'll jump in real briefly because in our community, you have to be credible messengers, you know, because our people, they don't accept just information from anybody. It's funny because when our leaders do get information like from the social media, whatever, they will reach out to us. And what's your guys' position on this is what I read, and they'll send it to us because they trust our reading of it. A lot of times we've already might have addressed it in a one page, like Anthony had mentioned, and sometimes we haven't at all. We'll read it and give them our position on it. But you have to be a credible messenger, and dealing with social media, you have to be able to check the sources. I don't even requote sources if I don't know where it came from. I tell people to quit sending me videos and stuff, because if you don't tell me where it came from, you just send me a random video. I don't even open it because it might contain virus, who knows? But you have to have credible sources, and you have to be a credible messenger.
Building on that with being a credible messenger, thinking too, who are credible messengers within the communities that you're trying to reach out to, and not just, and on social media, not just people who have very large followings on whatever platform, but people from just different types of spaces that could be those messengers, where you can build relationships to, you know, have ambassadors of communication, and, you know, helping share out that info authentically in those ways, and supporting those ambassadors by making toolkits that make it easy to disseminate that information. So for example, one of the projects that I do with NIH with trying to share information is, as an ambassador, like we packaged information. We learn about the research and we have access to the original, source, but also having, all right, we have infographics, we have a photo, we have some copy that you can make your own, but they're trying to make it very easy for us to be able to package that information and share it out. So that's something else that I think about when sharing out via social media. I mean, it's important, and all those different platforms are important because they're reaching different people. So avoid the trap of, oh, well, we're only going to focus on this platform, one or two. And I'm like, no, I mean, genuinely, people use a lot of different spaces, and with the misinformation that comes out, always have some ability for people to link back to the original source or to the organizations that are supporting that, or doing a call to action to say, hey, if you want to learn more about this, reach out in our chat or contact this person. We want to do engagement.
Yeah, I just wanted to add to that. Our communications department uses a platform, Hootsuite, that monitors misinformation or items that are gaining traction on social media. And when we see something like that happening, we go to our resources and start pushing out the accurate information. And I think one of the strategies that we also use is that we keep on top of, so for example, for years we've been putting out factual information about fentanyl. And then you all probably could remember that this sheriff's department had a video that came out where one of the sheriffs or deputies opened up a trunk and passed out. And they said that how he passed out because fentanyl was in the air and stuff like that. And later we found out that, they just, created the whole thing, right? But, things like that is being ahead of the game and putting out factual information. And as all the panelists said, from a trusted source, right? When those things come up, like when we get a ping on Hootsuite and saying how this thing is getting traction, we again put out the factual information to just double down on what we've already done.
Yeah, just to add on to that, really excellent points being made. I know, a lot of folks in the community might hear about something and then there might be a lot of, I don't know, I guess, commotion about it. And so people are posting about it, or people are sharing things without checking their sources, or just spreading that misinformation. And it can be very damaging because, it could ultimately, prevent someone from getting the help that they need. So I myself personally only have like a few organizations that I truly do trust and look at, and even people too. So like we talked about different advocates or ambassadors supporting different causes. There's a few people that I do trust, but it's because I know that they do fact check before they share things. They don't just share because it's in the moment and they want to add and get likes or something. It's not about that for them. Right. So it's more so about properly informing the community. And that is kind of hard to find it in some spaces. I know, like, for me, myself, like I primarily use Facebook, Instagram, kind of getting into TikTok, but it's kind of like the generation after me a little bit. So I feel a little older now. I'm trying to learn, but I don't know. But even to have like a TikToker explain a different, research finding and like walk through an article or something, maybe could be beneficial for some folks, who knows? So yeah, I think I agree with all the points that are shared. I don't have too much more to add.
Wow, this has been a phenomenal discussion. Thank you all so much. And I think, Sierra, this is a great time to go ahead and open questions from our audience. We already have one from Rowan McClellan Bishop. Sorry about that. The question is for Marissa, but I think it can be applicable to anybody. So coming from the perspective of an on-the-ground interviewer coming into the homes of research participants, I'm wondering what you wish your research interviewer would have known about how they could have helped you to feel more comfortable as a participant. And given their somewhat limited role as an objective data collector.
Oh, I love this question. So, and I know I spoke a little in my intro of feeling exploited at times. I think part of the reason that I have felt that way, and many participants do end up feeling that way, is there isn't always empathy when researchers are talking to us. There isn't always that understanding that, like, I've had a terrible day. I've had a terrible year, actually. You know, I've been through a lot of things. I'm dealing with trauma. I'm dealing with trying to get food today. I'm dealing with trying to, whatever, some weird relationship I have going on that I probably shouldn't be in, but I am, just to get my drug of choice or whatever. Who knows? You know, like there's a lot going on in my brain already. And so to have someone sit down with me and just like ask a bunch of really personal questions without like even just asking how I am, like, how are you today? You know, something as simple as that. I can't even keep up with the chat, but I did see a nice comment about just, you know, with harm reduction and showing compassion to folks. Like, that is key. People are people, you know, people come first. So like just relating to folks, even if you can't completely relate to what people are going through, just being kind goes a whole long way. I know, because I've now been in that position too, of being an interviewer and going to syringe programs and asking people very sensitive questions about their drug use and things like that and their relationships, and they're very sensitive topics. So like I always start off with, how are you today? You know, something as simple as that, because I actually do really care. You know, I think it's helpful for researchers though to have that perspective of like, we're just people like you, you know, we've been through a lot and we're still going through a lot, but ultimately that human connection can go a really long way and can keep us from feeling exploited and just like checking off a box for you to move on to the next person. And yeah, and I will say anything that I did participate in research wise, I never saw what came of it. So, and that also feels icky to me, exploitive. And this was years ago, mind you, been in recovery for a minute, but like it did feel a little, I don't know, just checking off boxes for people. So that's what I got.
Marissa, I love what you just said in your response. It resonates, especially the part 2 about not hearing back anything and how it's so transactional. Something else I would add is for the participants you're working with, find out from them what will support them to feel comfortable talking about that, and how you can be trauma informed and healing centered as you talk about this, because there's a component of the things that can come up for a person. And if your research team is not versed in that, do some training, do some reading, do some practicing, or talk to other folks in the community of these partners that can be supportive to help you become a trauma-informed, healing-centered person when you show up to ask those questions and to engage in that conversation. Again, essential because of the community you're working with.
Yeah, and if I could real briefly, kind of tangentially, I work with a lot of defense attorneys in the public defender's office. I consult with them, and they ask the same question: how do I engage my client? You know, they gotta represent people that's being taken to court, and oftentimes, you know, they're from different communities. I said, if you're not able to take a person directly impacted with you or whatever around the circumstance you're talking about, start with this: people don't care how much you know until they know how much you care. So ask them the question, you know, what's the best day in your life what's the best story in your life you can share? What was the best day in your life that you can remember? And just have an icebreaker, like Marissa said. Ask them how they feel. What's the best day in their life? I mean, what's their dog's name? Anything that personalizes, because if you start asking, you know, clinical question, that's off-putting. Now you asking intimate details about me as a person without even getting to know me as a person. So rule number one, they don't care how much you know till they know how much you care.
PIs and research teams need to understand that as they are, when people do focus groups and interviews, and Marissa, correct me if I'm wrong here. I mean, I've done research, my own research, but there's usually a format, a script that researchers use, right? And that's standardized across all the, and they're trained in that way, right? Don't veer off the script, right? So if you're doing a focus group, or even if you're doing a semi-structured interview, there's a script, right? And so it's how do you at the tape, like I was saying, how at the project, the research design phase, how do you incorporate people with lived and living experience at that stage to say, hey, listen, when you're developing the script, remember who your participant is, and put in the script something about that sort of icebreaker that Ronald was talking about, and at a reasonable time. Then you get into, the script. But and I think that how is this research frame of mind that everything needs to be standardized, and people need to go by the script, because if you don't go by the script, there's deviation and da 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 da. And that's just not how people work.
So I love a semi-structured interview, and thank you so much for bringing that up, because that's an important point as well. Like, a lot of us are trained to just ask these questions, and for data collection purposes, yes, we do, try to answer certain questions, and that helps with our qualitative data analysis and all of that. However, I mean, and I'm very blessed to be at the university that I am at. I don't know if other universities are like this too, but we do have a lot of researchers with lived experience, and we do curate a semi-structured interview that it can go any which way, and we usually study it pretty well before we go in. So, like, especially if I'm sitting down with someone who has been through all these things recently, I just want to have a conversation. And that's usually how I say it. I'm like, can we just talk a little bit about these things today? And I'm not going to ask the questions verbatim. I don't, even if I wrote them, that's usually not how they come out. And maybe that's bad for data collection purposes, but the point does come across, and typically my responses ended up being like a good hour long or so. And I felt like we needed to offer more incentive to people, because like we just really got talking, but it really helps with the data richness too, and just helps us kind of identify different issues that we hadn't even predicted we needed to kind of better address, at least in my state. So yeah, I think just being, I don't want to say like super casual, because you are still in a researcher role, but really identifying with someone as best that you can, and just keeping it as light as possible. And like, if some trauma comes up, you don't have to talk about that more if you don't want to. And just identifying and validating someone in that process is really, really important. So yeah, thank you for bringing that up, Anthony.
I just wanted to quickly just add in 2 points. One is someone had mentioned this in the chat about the limited information about being a trauma-informed interviewer. I was in the field of education for almost 20 years. I say go to the field of education and look at what research or what practices are being used to be trauma-informed educators. A lot of I feel like education actually leads in this area because, of, working with children and youth, but a lot of the types of approaches to being trauma informed is applicable across all ages. There's essence there. So, be open-minded to look from what does trauma-informed practice look like in other spaces, and take that and then be creative to think, all right, how are we going to apply this in our space? What could this look like? SAMHSA also has some resources, if you comb through their site too, about the pillars of recovery, the things that support people. You can look at that. I've done trainings for organizations about, thinking on how to be trauma informed informed as a peer specialist, how to be, aware of social emotional needs of the people you're working with. And so there may not be something that's already just like, here's these steps, but then look in the spaces where that's being practiced and take from that and adapt it. Also for, being open to mixed methods. I know a lot of the research around substance use, misuse, opiate disorders, a lot pull from quantitative methods, but be open to look at some ethnographic methods for interviewing, some other qualitative approaches for interviewing. I even encourage you to think about some of the arts-based research methods that you can pull from that can help gain some of that rich data and reflection that you cannot just get from a quantitative based survey alone.
Great. Well, thank you so much, panelists, for this wonderful discussion. For my next question, I'm going to paraphrase a question asked a little bit ago from Heather. So it's important that we make sure to explain things in simple terms that, our audiences will understand. But we also want to balance that with this feeling that those in the health world tend to patronize the patients and people with lived experience, sometimes without really knowing their health literacy. So how can folks in research dissemination strike that balance between making sure it's accessible and understandable and not patronizing or talking down to our audiences?
Anthony explained it earlier.
Ask them. I always say, go. Nothing for us, nothing about us without us, right? That's one of our mantras, right? Ask us.
I would just kind of go back to the idea of, sharing quick little, this is a summary of this finding. And if you'd like to know more, you can, follow this link, kind of as Kiana shared too. So I think too, like there are simple ways to explain things, and there are also ways that I can understand if it does feel like we feel like, oh, this population must not be have much health literacy or what have you, and just assume these things when that's not actually the case. A lot of SUD affects so many different people, so many different walks of life, so many different literacy levels. And so, we don't want to just assume these things. I think a lot of people have their own narrative in their mind of what someone with addiction looks like. And it's really not always the case. It's people who look like me or others even on the call too, yeah. So, and maybe I did look like that at one point, what your idea is or your perception is, but we're all the same. We're all people. I think there were some resources that were shared on just like health literacy in general too. But, I do like Anthony saying, nothing about us without us, just making sure that our messaging is being looked over by folks with experience. I think that's one of the best things that we can do. Yeah.
And just a quick, thanks, Marissa. Just a quick around the mutual aid, right? People need to realize that many community-based organizations, the vast majority, do not have access to journal articles, right? We've come a long way through open source and the National Library of Medicine, and NIDA requiring people to put, have access, have the general public access to their journals. But some are not, right? And so, what you end up, so institutions of higher education as partners with community-based organizations can say, hey, you're my partner, we are your ally. We can work some way out to give you access to all the online journals, right? And that is something that would go a long way to having community-based organizations do some of the things like get an article that's dealing directly with the type of work that you do and starting like a journal club, right? And getting someone to come in and explain the research and then how you translate it, right? How would you go about translating it? And I mean, I think that how community-based organizations, again, by nature of it, 501c3s don't have a lot of resources. Someone asked in the questions, you know, do any of you all evaluate your dissemination activities? No, we don't. Now we can measure click rates or the number of people that open our emails. We have the capacity to do that. We have the capacity to talk to people in our community, say, hey, listen, what did you think about X, Y, and Z posts that we did? And so we have that capability in terms of like whether or not posting on Facebook compared to sending emails, which one is more effective in X outcome. We just don't have that capacity. Now, we would love to partner with a communications department at IHE to say, hey, come on in and do that, but realize that we have a human resource capacity limit. And so if you're asking us to devote 1 FTE to help you do this work, we just can't do it, right? And so, I think the mutual aid is extremely important. Harm reduction is built on mutual, it was founded on mutual aid. And it continues to be that way. And we hope our community-based organizations hope that researchers and research teams can partner in a mutually beneficial manner.
So I'll ask this question from Genia McKee in the chat. Marissa had said that she wanted to see herself in the research. Would you please say more about that? And then, of course, the rest of our panelists, feel free to jump in after Marissa as well.
Yeah, so this can look a little complicated too. I mean, I think I'm saying that as a doctoral student at a university, you know, wanting to be able to have different roles, you know. But I do think it's also important for community members as well, who do have lived experience, to be a part of that process as well, if they'd like to. And maybe they don't know if they'd even like to if they're not presented the opportunity. So kind of what I'm thinking is, and I saw in the chat too, that community engaged research piece is really important. I mean, that's one of the gold standards. We really want to be involving people from the community with lived experience. It's amazing also to have researchers who have lived experience and can understand from that perspective as well. I think, you know, one of the, I guess, positions I was kind of making in my intro was in regards to being someone with lived experience and kind of changing roles a little bit to be in the research space, having these opportunities instead of just being seen as a participant to also be included on research teams as well and being a part of the actual research science, because that's how we learn. But I do think it's really important for community members to also be a part of that. And I don't mean, you know, like, hey, can you review this survey? Like, I mean, even before then, being a part of what do we need to include on the survey before we even build it? Or what do we need to be asking people in your community? What is important to you all? And what do you want to know? What do you want to see us be looking at and promoting and advocating for? You know, what should our research really be saying here? Because the research should very much be supportive of the community that it's surveying or interviewing or what have you. Part of research is advocating for change in our larger systems. So it's really important to involve everyone in that process.
Wow, thank you so much, Marissa. And I'm so sorry, we have to be mindful of everyone's time. So thank you all so much. This seems like a great place to end our discussion. And everyone, thank you again for joining us at this Heal Connection sharing session. We cannot thank our panelists enough for sharing your insights and your amazing voice, lending it to us. So thank you.
Thank you. Yes, I totally agree, Eden. Thank you so much to our wonderful panelists, to each and every one of you. Thank you so much.
We just want to also share that, you know, we love your feedback. So please take our survey on today's session. It can help us design, contribute to, and improve programming. We're going to ask you to stay tuned for an immediate follow-up with the link and a reminder to fill out our evaluation again. Then in 2 weeks, we'll send you the recording of today's full discussion. And then we hope many of you will join us for our next sharing session, evaluating and implementing a healthcare innovation. That session will be held on November 20th and will feature researchers discussing implementation guides and measures published by the Center for Dissemination and Implementation at Stanford and the Research Adaptation Support Center. So the link to register is in the chat, and we'll also follow up via email. I hope you all have a great and wonderful afternoon.